If you see patients with sleep complaints, whether you're in primary care, psychiatry, sleep medicine, or really any other specialty, you're already treating insomnia. Yet many clinicians are still assessing insomnia without a dedicated insomnia measure. We routinely use scales like the PHQ-9 and the GAD-7 for depression and anxiety, but for sleep, we often rely on just a few intake questions or maybe a single item that's buried in another scale. Okay, so there is a well-validated, brief tool that's designed specifically to measure insomnia severity and not just sleep difficulty, but also distress and daytime impact. This tool is the Insomnia Severity Index, or the ISI. In this video, I'll walk you through what it is, why it earns a place alongside tools like the PHQ-9 and the GAD-7, and how we actually use the ISI in clinical practice to inform care. I'm Dr. Nishi Bhopal. I'm a sleep medicine physician and psychiatrist, and this video is for you, the clinician. If you want to earn CME for this video, use the Learner Plus link in the video description below. So let's start with what the Insomnia Severity Index actually is and which patients it's designed for. The ISI was developed to create a brief self-report measure that could assess insomnia severity and its impact on daytime functioning. The ISI is a 7-item patient-reported questionnaire. It assesses difficulty falling asleep, staying asleep, and waking up too early. It also measures satisfaction with sleep, distress related to sleep problems, and interference with daytime functioning. That type of assessment is intentional because insomnia is not just a nighttime problem. Each of the 7 items is rated, and then those items are summed into a total score. The total ISI score ranges from 0 to 28. While scores shouldn't be used in isolation to make a diagnosis, there are some commonly used ranges that are helpful for context. A range of 0 to 7 indicates no clinically significant insomnia. 8 to 14 indicates subthreshold insomnia. 15 to 21 is considered moderate clinical insomnia. And 22 to 28 indicates severe clinical insomnia. So in practice, I use these ranges as information. They're not absolutes. They are useful for documentation and communication, but I'm also very interested in where a patient starts and how that score changes over time. The ISI is well validated, reliable, and it's sensitive to clinically meaningful change. So that makes it especially useful for tracking progress during treatment. Now, it's also important to be clear about what the ISI does not do and the limitations. So it's not a diagnostic interview. It doesn't replace your clinical history. It doesn't determine the underlying cause or causes of insomnia. But that's actually a design feature. It's not a flaw because the ISI is meant to quantify severity and impact. It's not meant to replace your clinical assessment for judgment. So who do I actually give the ISI to? In my practice as a psychiatrist and sleep doctor, I give it to pretty much any patient where sleep is a presenting complaint, or it's a factor that they're concerned about, or it's a meaningful comorbidity. This includes patients with insomnia disorders. I'll also use it in other disorders where insomnia symptoms are prominent, including mental health conditions like depression and anxiety, where insomnia commonly co-occurs. In terms of age, the ISI has been validated for use in patients aged 17 through 84. I also use the ISI in multiple treatment formats. I use it with individual patients, and we also use it in my online group coaching program called Effortless Sleep. In both settings, the value is the same. We're able to track severity of insomnia, distress about their sleep issues, and daytime impact in a consistent way. If you are a clinician who wants to go deeper into sleep assessment and treatment, especially how to integrate tools into your practice, I put together a free sleep mini course designed especially for clinicians. It is short and practical and focused on how to think about sleep the way that a sleep specialist does, without adding more complexity to your practice. You can get it at IntraBalance.com/doctors. The link is also in the video description below. Now, in practice, I often see patients where their mood scores improve, but their insomnia symptoms and the ISI remains elevated. So that tells me something very different than if both improve together. So if the PHQ-9 is improving, but the insomnia severity stays high, I'm thinking more about conditioned arousal, maladaptive sleep behaviors, circadian misalignments, and sometimes sleep improves first, while the mood symptoms lag behind. So all of that information is clinically useful in formulating your treatment plan. So once you decide to start using the ISI, the next question is practical. How do you integrate this into your clinical workflow? In my clinic, the ISI is built directly into the EMR. Patients receive it electronically before the first session and then again at follow-up visits. But not all patients will fill it out before their session. So you can also do it during the session itself because it only takes about 2 to 3 minutes. There are a few key points where the ISI can be especially helpful. These include the initial assessment, where you can establish a baseline, treatment planning, and that helps to inform goal setting and selecting an intervention, monitoring progress, where we re-administer about every 2 weeks, and then again at termination. So you can assess change post-treatment and their overall response. In practice, the ISI can be particularly helpful when you are addressing sleep through sleep hygiene education, CBTI or cognitive behavioral therapy for insomnia, and even if you're using medication management, where you're monitoring the response over time. When I review the ISI data, I'm not just focused on single scores, I'm also interested in trends, especially with regard to changes in distress about sleep and their daytime functioning. So looking at these trends over time helps to inform whether you need to stay the course with treatment or if it's time to adjust treatment or perhaps reassess the diagnosis. The Insomnia Severity Index is a brief, well-validated, reliable tool for measuring insomnia severity, distress about sleep, and daytime impact. When used longitudinally, it can become a feedback tool that helps to inform ongoing clinical care. If you're already working with patients who struggle with sleep, you don't need to overhaul your whole practice to start using the ISI. It's a small, easy addition to your practice that will bring more structure and clarity and better outcome tracking when you're treating sleep issues. If you're thinking about other sleep measures like how to assess daytime sleepiness, tools like the Epworth Sleepiness Scale are a good next step. So I'll do another video on that. Watch my next video on what to do before you prescribe your next sleep aid. I'll see you there.